Welcome to this video on upper respiratory tract infections, or URTI, in children. URTIs are common and mostly viral. We will focus on safe management, differentiating causes, and prioritizing treatment. The illustration shows the upper and lower respiratory tracts, with the infection generally above the larynx. An URTI is an infection above the larynx, involving the nose, sinuses, and pharynx. This includes common cold, tonsillitis, and sinusitis. The adjacent image illustrates the anatomy of the upper respiratory system. URTIs are very common in children, with 6 to 8 infections per year being typical. They are mostly viral, spreading through droplets, and peak prevalence is often observed in school-age children. The etiology of URTIs is predominantly viral, including rhinovirus, RSV, influenza, and parainfluenza. Bacterial causes are rare, but include Group A Streptococci and Staphylococcus aureus. The pathophysiology begins with viral entry, leading to inflammation and increased secretions. This causes obstruction, which ultimately results in the clinical symptoms. Typical clinical features of a self-limiting URTI include fever, rhinorrhea, cough, and a sore throat. It's important to identify red flags early, such as stridor, drooling, inability to swallow, high fever, a toxic-looking child, or neck swelling, as these can indicate a more serious illness. Viral URTIs typically have a gradual onset with cough, runny nose, and mild fever. Bacterial infections tend to be sudden, present with a high fever, and often lack a cough, helping to differentiate them clinically. Management involves supportive care with fluids and antipyretics. Saline can help with nasal symptoms. Antibiotics are used selectively. Safety netting advice is crucial for parents. Viral nasopharyngitis, or the common cold, causes subjective discomfort, nasal mucosal inflammation, and profuse nasal discharge. Secretions are initially clear, becoming cloudy white, and can turn yellow or green even in viral cases. Foul breath and fever may also occur. Tonsillitis and pharyngitis are most commonly viral. Bacterial pharyngitis is rare, with Group A streptococcal being the commonest cause. Signs include exudate of the tonsils, high temperature, and tender anterior lymph nodes. Treatment for bacterial cases is with oral penicillin or amoxicillin. Antibiotics like penicillin V or erythromycin are prescribed in severe streptococcal cases and may hasten recovery. Importantly, a 10-day course is required to eradicate the organism and prevent complications like rheumatic fever. Complications of URTIs include otitis media, sinusitis, and paratonsillar abscess. These illustrate the potential spread of infection and the need for ongoing monitoring. We will now focus on acute otitis media. Acute otitis media is very common in childhood, often peaking between 6 and 12 months of age. Predisposing factors in infants include short, horizontal eustachian tubes and poor eustachian tube function. Clinical features include ear pain and fever. It is important to examine the tympanic membranes in every febrile child for findings such as a bright red, bulging membrane, loss of the normal light reflex, or possible perforation. The etiology involves both viruses, like RSV and rhinovirus, and bacteria, such as pneumococcus, Haemophilus influenzae, and Moraxella catarrhalis. Rare complications include mastoiditis and meningitis. Management prioritizes pain control with paracetamol or ibuprofen as the first line of treatment. Antibiotics, specifically amoxicillin, are indicated for children under 6 months if ear discharge is present, or in severe cases. To summarize acute otitis media management, pain control is first line. Antibiotics are reserved for infants under 6 months, those with ear discharge, severe symptoms like high fever or persistent pain, or if otorrhea is present. Amoxicillin is the standard first-line choice. Epiglottitis is an acute, rapidly progressive infection of the epiglottis and supraglottic structures, which can lead to a life-threatening airway obstruction. While Haemophilus influenzae type B used to be the cause, vaccination has made it rare. Now Group A Streptococcus and Staph aureus are more common. In epiglottitis, bacterial invasion causes intense inflammation and edema, leading to rapid airway obstruction. Crucially, do not attempt a throat examination as it can precipitate sudden airway obstruction. The image illustrates the swelling of the epiglottis. Clinical features of epiglottitis include drooling, dysphagia, distress, high fever, and stridor. Children may adopt a tripod position and have a toxic appearance, but importantly, they will have minimal or absent cough. Management of epiglottitis prioritizes the airway first, requiring urgent involvement of an anesthetist and ENT team for controlled intubation. General measures include keeping the child calm and administering oxygen if tolerated. IV ceftriaxone, or cefotaxime, is the antibiotic treatment, followed by ICU care. Croup, or acute obstructive laryngitis, is a viral inflammation of the larynx, trachea, and bronchi, causing subglottic edema. This leads to airway narrowing and stridor. It's commonly caused by parainfluenza virus and affects children between 6 months and 3 years. The pathophysiology of croup involves a viral infection leading to subglottic swelling. Due to children's narrow airways, even a small amount of edema causes significant obstruction. This results in turbulent airflow, causing the characteristic stridor and barking cough. Clinical features of croup include a barking cough, inspiratory stridor, and hoarseness. Diagnosis is primarily clinical, and no routine investigations are typically needed. Management for all croup patients includes a single dose of dexamethasone. For moderate to severe cases, nebulized adrenaline is used for its rapid but temporary effect. Oxygen should be administered if necessary. Next, we will discuss pertussis, also known as whooping cough. Pertussis is an extremely contagious acute respiratory tract infection caused by the gram-negative coccobacilli, Bordetella pertussis. This bacteria secretes toxins that cause local epithelial damage, leading to respiratory symptoms and nearly 100% spread among close contacts. Pertussis progresses through 3 stages. The catarrhal stage, lasting 1 to 2 weeks, is highly contagious and mimics a common cold. The paroxysmal stage, lasting 2 to 4 weeks, is characterized by spasmodic coughing. The convalescent stage can last weeks to months with a chronic cough. Diagnosis of pertussis is clinical and confirmed by a culture of deep nasopharyngeal aspirate, or PCR. Treatment involves limiting paroxysms and using azithromycin in all age groups for treatment or post-exposure prophylaxis. Prevention is achieved through the DTP vaccine.